Type 1 MPGN. Most common type, it is nephrotic syndrome presentation. What does that mean to you? You begin with protein loss. Greater than 3.5 grams of protein per day. Hypoalbuminemia and generalized edema. You would have loss of antithrombin 3, anticoagulation, maybe a little bit of hypertension. That's your nephrotic presentation, isn't it? Some cases will have nephritic. I told you earlier that MPGN and DPGN will have a little bit of nephritic, a little bit of nephrotic. Now, most of this with MPGN, in fact, is nephrotic. Associated with hepatitis C, more common, or cryoglobulinemia. What does that even mean? That means that you might have conditions, and at some point in time, when we get into cryoglobulinemia, there are 3 different types, 1, 2, and 3, cryoglobulinemia, the big ones. Type 1 associated with multiple myeloma. Type 2 and 3 more or less associated with infections and autoimmune diseases. What do all of these have in common? Autoimmune diseases, monoclonal gammopathies, and hepatitis C could be put in there as well. They're associated with antigen-antibody complexes. They are associated with antigen-antibody complexes. Okay, 2 components circulating through the body. All of a sudden, cryo. What's that mean? Cold. Exposure. The globulins will precipitate, resulting in all kinds of issues in your patient. Mostly, well, you know this about Waldenstrom. In Waldenstrom, what then happens when you have your globulins that will precipitate in the blood? It's almost like a thrombus, isn't it? And so therefore it's hyperviscosity. Cryoglobulinemia is a big deal, a big clinical condition or syndrome. And I've given you a few examples of type 1, type 2, type 3. My point at this point, though, what kind of MPGN are we dealing with? Type 1. In the previous discussion, what branch of our MPGN would that follow? Immune complex mediated, or would it be complement mediated? Good. Immune complex mediated. Much more common. Type 1. With type 1, on your light microscopy, can't really tell the difference between type 1 and type 2. That I can tell you for certain. However, where you can start seeing differences, when you hear, at this point, this is reflexive. When you say subendothelial immune complexes, what kind of biopsy is this? Good. Electron microscopy. If you say granular pattern, what kind of biopsy is that? Good. Immunofluorescence. Are you feeling good about this now? You're reading as if you're reading a clinical vignette. You're reading as if it was a medical journal, Lancet, New England Journal of Medicine, whatever it may be. And this is the kind of information that it has, and you should be able to, these are the kind of questions, information that everyone expects you to know at your level of medical education. The immune complexes activate classical and alternative complement pathway. You know that already. Electron microscopy shows triamtrack. What's that even mean? Triamtrack means the membranes being involved, membranoproliferative. The membrane's been involved, what happens? Split of the glomerular membrane by ingrowth of mesangium. Triamtrack. Is that specific? No, it's not. Anything that weakens that membrane, do you think that you would then have deposition of mesangium and splitting of it? Sure. Another good differential? Alport syndrome. Hypertension, 35%. Majority of your patients will have hematuria. Remember MPGN, nephrotic presentation. Majority will progress to chronic renal failure. Which one's more common? Type 1 or type 2? Type 1. If it's type 1, what kind of association? Immune complexes. Examples, autoimmune diseases, infections such as hepatitis C and cryoglobulinemia. And we have monoclonal gammopathies, including Waldenstrom. With type 1, response to corticosteroids not established, let it go.